Well, welcome everybody. Dr. Busti and Dr. Boland. We're on tonight for some primary care, ambulatory care. Can somebody give us a quick note in the chat if you're hearing us and you're seeing the video feed, please? You can just type in the question area. Perfect. Thanks, Randy. All right. Thanks, guys. Okay, so it sounds like everybody's on and we are ready to go. So just a little bit of reminder on a few things. Each of these sessions have a little bit of a focus. The schedule with the breakdown of the topic area, like cardiology, endocrinology, dermatology, whatever the topic is to be, is listed on the website under the resources portion of the menu, CE webinars. There's a schedule that you can then download and print off a PDF file. So tonight's focus is going to be on ambulatory care, chronic care, outpatient sort of perspectives on the management, recognizing that if anybody is attending that's focused on a more inpatient side, that doesn't mean that this is irrelevant. Our patients from the outside and ambulatory care side do come into the hospital. Just like I saw yesterday, type 2 diabetic who's uncontrolled coming into the emergency department. I have to understand what's happening in the outpatient side when I see that patient, so that when I discharge them out of the hospital back, the outpatient providers need to understand what happened on the inpatient side and maybe how things were manipulated to treat the patient so that there's some continuity of care. And so that'll be our focus tonight. Dr. Boland is joining us. So as a quick intro, we do have a specific CE or CPE associated with each of these events. Today's event will be 1.5 CE credits, and the numbers are listed on the handout that is actually associated with your tool on the right. So you should be able to download it. The exact instructions are there for you. There have been quite a few number of people emailing in saying, how do I get my CE? It is very explicitly outlined exactly what you need to do, what your link you need to click on, and what information you need to put in, okay? But there's a live credit, and then there's the home study credit. This is my sort of disclosures. I don't have any other than the fact that I did start the company. And so I've been with the company from the beginning and don't plan to go anywhere. At least nobody's told me that yet. I don't know who's going to fire me, I guess, but maybe one day I will. And then this is Dr. Boland, who's also, you guys can see online with us. She's one of our consultant editors as well as contributors. She's contributed to the QBank and some of our other material for a number of years. She actually has a unique background in that she has done multiple areas, including even a little bit of emergency medicine. I like to brag on that point. But where her focus and most of her energy and time has been in the ambulatory care, especially over the last couple years in clinical practice. And so she has no conflicts of interest, to just sort of get to some of the points. So we've got three main objectives that we need to cover. And this is important for not only your CE credits that we make sure we address, but it's also important that you understand what is the purpose of this tonight's event, where we're going through cases. The idea is integration of knowledge. So you heard probably in the first session when if those of you that are coming back, we follow a tiered based approach where we take that core knowledge and we build on it and add to the depth of our understanding of why do we do what we do for a particular patient? Why do we order this lab or use this medication in this patient, but we do something slightly different for another patient? That is that tacit level knowledge. And then hopefully we get to the point of true competency where we're providing good patient outcomes and clinical excellence, which is what the board's certifications are really trying to identify. Do you have the ability to take that explicit and tacit knowledge and apply it through a higher level of critical thinking and analysis? So we use selected cases to give you the idea of where you should be when you're studying the material, okay? And so tonight we'll be learning a little bit about some of our common chronic cardiovascular diseases. So what are some common factors evaluated when we assess a patient's risk factors for cardiovascular disease? And I don't have it online, but I've pulled, and I do have in front of me, the blueprints that are published on the BPS website for the various domains that you cover. And if you go through some of these, you will identify the fact that you need to know how to risk stratify patients. You need to know how to triage them. You need to be able to then discern what are those risk factors so that you can appropriately put them in the right bucket, if you will, on how to manage them. How aggressive do you need to be? And we're going to do a case tonight where we actually walk through that a little bit in detail. Then we want to describe the difference between primary versus secondary prevention, because a little bit of our approach is different. Even some of the medications that we use, treatments we recommend, are evidence-based in a particular context. For example, aspirin's primary evidence is in secondary prevention of cardiovascular disease, not primary prevention. Okay, so we're going to talk a little bit about what are those differences and why do we want to really hone in on primary prevention in patient care, because it really tries to get to the root of the problem before it becomes a problem. And then we're going to list some common drug therapy options that are known to improve mortality as well as maybe at some level of morbidity in common cardiovascular diseases. And so as we go through these cases, they might feel like, typical cases that you might see in clinical practice and on the boards. But the idea again is here, how should you be learning and studying the materials? So you got lectures, you got Q-Bank questions, you're participating in these study groups. As you're studying other diseases, what should you be doing with that information as you do it, right? So we have a learn, practice, apply sort of approach to our method. And then at the end, we're going to do a rapid review option that you'll have access to. Okay, so let's start out with our clinical case. Okay, we'll kind of break this down kind of like we were in conference or like we're sitting in the clinic and we're seeing a patient. And so we'll start off with our first clinical case. This is a 42-year-old female with no past medical history who comes in the clinic. Okay, so that's identifying obviously the practice area. So they're giving you a little bit of information. There's a pattern of association in any question or case that they're trying to drive you into. She has symptoms of weight gain, 25 pounds over the past year and a half. That's quite a bit for somebody who's already a middle-aged adult who's sort of not on a growth curve like a pediatric patient, right? So something has happened in that year and a half that's obviously relevant, and they're trying to draw a little bit of attention to it. They feel tired, constipated, feeling depressed at times. So just there alone, okay, because you remember, you should just be thinking. Let's just pay attention. Don't try to write down everything. You need to think about how you're going to apply, because that's what's going to happen on the real exam. What is the pattern of association they're saying? What are the disease states? What pathophysiology aligns with this pattern of association? That's what you want to think, because you always want to treat the underlying problem. You don't want to just throw a drug and put a Band-Aid over a situation or treat a number. You're treating a patient with a disease or an underlying process going on. And so the questions that come up on board exams are purposeful and strategic at driving you to the right answer. So she's really not on any medications. She does take a multivitamin. That is obviously a medicine. But for the most part, nothing really of significance, no known drug allergies. Let's look at the family history, right? Because again, she's middle-aged, okay? You don't know yet if she's menopausal or premenopausal, postmenopausal. Most people would stereotypically say, she's probably not gone through menopause yet. Although some women, again, fall on a bell curve, will go earlier. Yes, 50. It's not like when you turn 50 on your birthday, you automatically stop having periods, right? There's a transition that occurs in that. But the reason that this becomes relevant is that we know when women do go through menopause, in the back of our minds, what should be circulating in the back of our minds is, okay, this is where her risk for cardiovascular disease really starts to catch up with men, okay, because she loses that estrogen effect. All right, so she has a mother who had an MI at 56, okay? So that's a primary first-degree relative, not great-great-grandpa or grandma or distant aunt, okay? This is a primary first degree relative. It's her mom, right? Father has hypertension, hyperlipidemia, and gout, and is still alive. So both of them are still alive, but it's important to recognize what constitutes family history. Cassie, or Dr. Bowl, I didn't mean to call you by your first name, but
It's okay.
you know, these things come up a lot, and a lot of times patients actually are caught off guard by this question. At least in my experience, I don't know how many of your patients actually can recall some of this information, but we really should be asking it. I don't know if you have any comments in this particular area, because this is part of that risk assessment.
Yeah, it's definitely important to ask. And, you know, I find that patients who have had a parent who had an event at a younger age do tend to know the age, or at least round about the age.
Yeah,
I tend to find when it's older and they typically expect it more, that they maybe don't give an answer, or are not sure. They're like, well, they
right.
were 70 something, or that was what killed them when they were, you know, whatever,
Yeah.
unfortunately. But when it's younger, I find that they do tend to know, because it was a major
A
event.
noticeable
So,
event that
right.
got their attention, that they were aware of. Absolutely. What is not listed on this slide that's important, because some of you might be saying, well, wait a minute, Dr. Bustai and Dr. Bolin, you guys only did a partial exam on the family history. Where are the siblings? Because the siblings should be involved in that as well at some level, right? So if you have a brother or sister at an early age having an event, you're looking for literally like kind of patterns of familial hyperlipidemia, where, you know, members of the family will develop heart attacks in their 20s and sometimes die in their 30s. And so she doesn't have any siblings, so it's just she's an only child. She denies smoking. She has a social alcohol use, and people describe that. Don't automatically assume that social alcohol use does not mean daily. They might be socializing every day. And then no IV drug abuse or illegal substances that are being used. Okay. Vital signs look pretty good. Her blood pressure does appear to be elevated, but this is a single blood pressure in the clinic. Respiratory rate looks good. Pulse ox on room air looks really good. Now you're given a weight here of 84 kilos. She weighs about 184 pounds. You know that over the past year and a half that she's gained 25 pounds. So if you just do a little bit of the math, you know, she's kind of hovering around 150 to 160, that kind of window. And so something obviously happened. But what does this mean? Well, you need some other information sometimes to put that in proper context. We'll come back to that. General description, you know, she's overweight, no acute distress, cardiovascular, pulmonary exam are normal. And again, you might go, you know, Bustai, why are you talking about physical exam findings? Because when I read the blueprints for BCACP and BCPS, it actually says you need to understand how to interpret those. I don't know what kind of questions they're technically going to ask you, but I think it's in the context of a case, and that's why we put them in here. Decreased bowel sounds, but no abdominal distension. Well, what did she present with was part of her HPI or symptoms? Constipation. So does constipation and decreased bowel sounds coincide with something? Absolutely. They should match up at some level, because that tells you a potential functional problem within her GI tract that may be secondary to another problem, right? You start thinking about medications automatically, but it's not always a medication that does that. Her skin is warm and dry. So let's consider a few things, okay? So, you know, what could be going on? We need to think about our differential diagnosis. Most people want to, and a lot of clinicians, especially early on in their training, when they're less experienced, will diagnostically anchor immediately on something, one diagnosis, and they forget to stop and think about the other things that also could be going on. And so we got one person mentioning heart failure here. That certainly can be, but let's think about a differential diagnosis. What are all those symptoms, some of those initial findings, what disease states? Again, not that you have to be the complete diagnostician, but you're still triaging and recognizing patterns and problems. So let's think about some of those differential diagnoses. Anemia, does that make people feel tired, feel weak? Sure it does, but it doesn't usually cause people to gain weight, right? Anemia is not associated with constipation. So it's a diagnosis that correlates with some of her symptoms, but not 100%, right? So it's what's the most likely diagnosis. How about diabetes? When you gain weight, can you develop insulin resistance? Can you start having energy changes and fatigue? Sure, right? And we know that weight changes do correlate both with type 1 and type 2 diabetes at some level. We got depression. Maybe this is all psychiatric in nature, and the psychiatric problem which needs to be treated will treat the other problems that are starting to occur in her life. Hypothyroidism, again, looking at the pattern of association. Polycystic ovarian dysfunction, okay, and why would that cause some of her presenting symptoms? Well, PCOS patients develop big cysts on their ovaries. Polycystic ovarian, right? I mean, the name tells you what the problem is. And these women tend to be a little bit more pear-shaped. They have a little bit more abdominal adiposity, have insulin resistance, hirsutism sometimes. They have produced a little bit more androgens. And when they develop these cysts, those cysts press on the bowel, and it can commonly cause not only abdominal pain, but constipation. What about IBS with a predominance of constipation? We know that IBS patients, irritable bowel syndrome patients, typically also have a psychiatric illness associated with their diseases, as well as a gastrointestinal problem, and it could be diarrhea, mixed, or constipation. Lifestyle nutrition issues. Maybe she started a different, maybe a new job and she has no time to exercise, and now she's eating fast food every day. All of these things, plus probably 5 or 10 more. Let me just see if anybody's listing any. We've got a couple. Yeah, most of you are saying hypothyroidism and or a life event. I like that. So did something happening that was very important in her life? Did she go through a divorce? Did she lose a family member? Did she move? Does she something bad going on at her job? There's a lot of things that can cause life-changing events, but something happened, right, in her life. All right, so as we start thinking about that, we may not still know what's the diagnosis. And that's where we have to order labs or get some more information to help us do the workup, no different than you would do in the clinic. So when somebody comes in with a new diagnosis of diabetes, there are things that you need to check, right, Dr. Boland?
Yes.
Like what are some of the consults or things that you would do in your clinic when you would see a newly diagnosed diabetic?
Well, I mean, you mean like labs and things that we would have looked
Oh,
at, or?
just anything. Like, do you consult other colleagues? Do you do referrals? Do you have them see certain people? Do you order certain labs?
So, I mean, for sure, we start having a conversation about those life events and if there's been significant dietary changes and things like that. Or if not, and maybe they just have never learned those things, you're certainly going to, consider a nutrition consult or dietitian
Absolutely.
or something like that. And then I think you have to, get some more labs. If they've got some signs of CKD, if you've got some albuminuria or,
Hmm.
decreased GFR, you may then refer to a nephrologist for that to get checked out. If they've got some difficult foot exam findings,
Podiatrist.
a
Mhm.
podiatrist.
Yeah.
And of course, if they mention blurry vision, they're going to an ophthalmologist. And even if they don't, if it's initial, you're sending them that way. So a
And
lot of things going on.
and some of this is also getting a baseline. If they are having some slight vision changes and they may not be losing their vision, but diabetic retinopathy is a real problem.
Yes.
If they start going blind, how are they going to read the bottle of the medicine they're taking? I mean, simple things like that we sometimes forget about. The other things that we mentioned, Dr. Boland mentioned, was something about the feet. Diabetic neuropathy. I've had patients literally come in the emergency department saying my foot is bleeding, and I look at their foot and there's like literally a hole in the plantar surface of their foot right over the metatarsal heads, and I'm like, wow, that looks like purposeful digging in a hole. And I then pick up the shoe and I look inside the shoe and I see the nail sticking up through the sole of the shoe, literally like this, and their foot is just on top of it and they don't even know it. Then I turn the shoe around and I can see the bottom part of the nail anchored at the base of the shoe. I was like, sir, you got a nail in your shoe. Oh, wow. Like, I didn't know I was walking on that. Yeah, because they can't feel it. So this is where doing diabetic foot exams, but also if somebody's got really bad nails or hyperkeratotic lesions on their foot, a podiatrist can help, shape those toenails so they don't dig into the skin and cause compromise the skin integrity, which increase risk of infection. Some of these toenails, if you've probably seen them, have a lot of onychomycosis, toenail fungus, and they just need to be removed, quite honestly. And then you got dentists, so they want to keep their teeth so they can have good nutrition. A lot of people, Dr. Bowen mentioned about diet, nutrition, and even maybe referral to a nutritionist. Again, these things are on our mind. Why? Because people have developed bad habits. They don't even know. They may never have been modeled what appropriate portion sizes look like. We're warped in America on what an appropriate, everything's size it up, right? You want to add it on, you want to mega size it, whatever. We have a warped perspective of a portion size in this country. And so sometimes we have to physically show somebody, this is what a typical meal should be for your age, height, weight, and all that business. Oh, that's a little off. I'm sorry about that. Labs. So we would get typical CBC because that would help us to rule out a anemia, right? BNP, basic metabolic panel, or comprehensive metabolic panel. And I put a little question here. Why might we want to consider ordering a CMP over a BMP? And you might be like, well, I don't know. What's the difference between a complete versus a basic metabolic panel? Well, these metabolic panels are things like sodium, potassium, chloride, BUN, creatinine, glucose, but it also adds in most cases, liver enzymes, AST, ALT, T-bili, and alk phos. And why might you want to do that in this patient? Well, again, thinking 2 or 3 steps ahead of everybody else, right? She's gaining weight. Maybe we don't know yet if she has diabetes, that this glucose might help us see that, right? Does she have fatty liver disease starting to happen? Because you'll see elevations in AST and ALT. And those are the earliest signs that can eventually, if you leave fatty liver disease untreated, can lead to cirrhosis of the liver. Fasting lipid profile. Again, this is about primary prevention. TSH, many of you picked up on the hypothyroid pattern of weight gain, fatigue, feels depressed, gaining weight, all those things. That would definitely be something. And then goodness, yeah, she's in her 40s, but don't exclude pregnancy. I've had a 48-year-old patient, come into the emergency department with abdominal pain. And I said, well, ma'am, do you think you might be pregnant? No way. She went all crazy on me. I was like, okay, well, that's cool. I just wanted to make sure because you're telling me, you still have periods. And she's like, there ain't no way I'm pregnant. I put an ultrasound on her abdomen and I'm like, I turned the screen to her, I was like, ma'am, you are pregnant. And it looks like you're about pretty close to delivering here. And the next day she delivered. And you hear these stories like there's no way someone could not know they're pregnant. Well, I live to tell you the truth. I have seen it happen. She started screaming at the top of her lungs so loud that all the attendings and staff came running over to my room thinking I was killing this lady, right? But she was so out of control that she was pregnant because she thought she was done with all that. And the next day she had another kiddo. Oh, well, there you go. Welcome. So what about her blood pressure? Does she have hypertension? And so let's do our first poll of the evening here. So I'm going to release this poll. Again, nobody knows who you are in the sense that they're going to see your answers. So just participate. I'll give you guys 35, 40 seconds because this is a really straightforward sort of question. It really highlights whether you guys as a group or class are sort of seeing the pattern or are you looking at information appropriately. So we're at 21 seconds, and we got about 50% participation. All right, come on, you guys. Stop shopping on Amazon unless you're buying something for me. I like beef jerky if you're ordering anything. I kind of one of those things you go hiking, you know. All right. Let's close the poll, share the results. So the good news is some of you are saying, well, maybe. And that's actually probably the most appropriate answer. Those of you that are saying yes, you're saying yes because you have a single blood pressure reading. And that's a little bit of a problem if you anchor immediately on a single reading, right? Some of you are saying no, and I'm not quite sure how you discern that either because her blood pressure technically is elevated, okay? So let's talk a little bit about what the alphabet soup guidelines say about blood pressure. And I use the words, I say alphabet soup here because for those of you that are young, unlike the old people who have been around since JNC 4, 5, and 6 and saw,
7.
yeah, right. And so when you watched the guidelines over the years, one of the things that I noticed as I aged and got younger was that the a number of stages of blood pressure have shrunk, right? They've become a little easier to remember. Like there used to be like stage 1, 2A, 2B, 3, and I'm like 3.25, and I'm like, come on. I mean, first of all, nobody's blood pressure is static 100% of the time, right? I mean, come on. I mean, I could check it 1 minute and 30 seconds later, I can check it again, you're gonna get different numbers. It just is a moving target, but there should be a general average for what you are seeing in in a patient. The other thing is blood pressure really doesn't change whether you're in the United States of America or Africa or Europe or, you know, wherever, India, it doesn't matter. Everybody gets a blood pressure, you measure it the same way. So is there some level of agreement that we can come to so that we don't have conflicting guidelines that make our job more difficult when we see discrepancies? Because a lot of times I see this happen where we hyper focus in on a number and we treat them as absolutes, okay? Nothing in medicine or healthcare is typically an absolute except VTAC and VFib or STEMI, right? I mean, when you see those, they're like slam dunk. That's STEMI, let's go. You know, so there are very few things in life that work perfectly. But what I love about this group that came together and finally held hands and sung Kumbaya together is that they said, look, we need to make this easier for busy clinicians, but we also even need to help our patients understand. And over, I don't know, Dr. Bolin, if you've seen this too, but there's been this movement of like what's normal, 120 systolic, 130. There was at one point it was 140, right? And then it kind of came back down to 130. I don't know if you have any take or opinion or observation about that as well that you'd want to, you know, add in here, but thought I'd ask you since this is one of your areas as well.
Yeah, I mean, I've definitely seen it go back and forth. You know, for diabetes patients, it was, you know, we had the Accord trial, which threw everybody for a loop because we just knew that was going to say, you know, less than 120 over 80, and we were going to drop everything down. And then we found that, well, maybe it wasn't. But now, earlier this year in the spring, then you've got flipping over to the CKD side of things. Now they've got the end of the Sprint trial that they
Yeah.
followed out, and they're saying, well, now for patients without dialysis, you're down to 120 over 80 again, which includes a lot of your diabetes patients. So how is that going to cross over to the ADA? So it is very frustrating when you've got a patient with diabetes who has CKD, who
Yep.
also has hypertension, and you've got 3 different guidelines giving you within 10 millimeters of mercury difference of a goal.
Yeah.
So how do you decide what's best to do? And then that comes down to the clinical side of things, which, you know, is looking at your patient, talking to them about adherence, talking to them about adverse effects and all that stuff. So,
Absolutely. You bring up a fantastic point that we brought up in our, precursor webinars to these series where we talked about how to pass and take board exams and these kind of things. And, this is where a board exam gets themselves potentially in a bind. When you have 2 or 3 sets of guidelines that have different parameters or recommendations because they view the world in this lens here, this lens here, but now you've got a patient that crosses over. So either the board exams can't include patients with multiple comorbidities because they know if they're fully understanding the guidelines as a whole, then they know that there's no right answer. They're going to there's multiple answers, correct? Those are not good test questions, guys. And this is where the fallacy of being too hyper committed and focused on guidelines as absolutes comes. They are meant to be a guide. It's like, look, we're trying to get in this ballpark, and we know that we need to treat some patients potentially a little bit more aggressive than others, knowing that some patients in certain patient populations, if we get too aggressive, then we could actually potentially worsen outcomes. There's a balance in this, but it makes it difficult for board exam questions then to be put on your test where you're held accountable to it, where there's conflict, unless they identify very specifically, according to this set of guidelines, what would be the goal blood pressure for this patient in the context of their CKD. That's what they would have to say to do a proper validated question. And so, Dr. Bowen, thanks for bringing that up because you reminded me of something very important that makes it difficult. And I highlighted this on the previous sessions where we've gone through this topic for board exams. You got to play the game. So what do guidelines have that is consistent? Those tend to be good questions because there's not a debate about it. Obviously, this expert group over here believes this expert over here group also believes this. And that's why when I say alphabet soup guidelines here, where you see all these, organizations, this is nice when you have consistency across focus groups, because it says that we all consider this the same. So here we have a patient who's
if I could
coming.
just add one thing there too, in
Yeah,
talking about playing the game and looking at the exams too. If they're giving you something and you're going, well, there could be, 3 or 4 answers here. There's something else that is differentiating that patient that makes something clearly right or clearly wrong.
yeah.
And and as a clinician, not just as a test taker, but as a clinician, you've got to identify, well, that's a hard no, or this is a hard yes for this patient that, I need to move towards those.
Absolutely. So we have a patient who's come to clinic really for a primary prevention, what appears to be a problem, right? Has no medical history. She's no medicines. You're getting you're getting vital signs, and you're collecting labs and all this stuff, and you've got a single blood pressure reading, and therefore, what do you do with that? Do you treat a number on a monitor, or do you treat a patient who lives in a continuity of the 24-hour period in days, right? So this is where white coat hypertension, people get a little bit anxious, they get worried, they don't want to hear bad news. She's already depressed, she doesn't want to hear more negative information. She knows she's gained 25 pounds. She's probably not super excited about that if you were to ask her, which I would not, ask that question, right? But you see, the point is that, sorry, I've been in the doghouse more than once. You don't want to go there, but people their minds get turning, and that can falsely create a reading. How about even crossing your legs during your blood pressure reading? You're not supposed to cross your legs. They're actually supposed to be laying straight, feet flat on the ground. Your arm needs to be at the level, right? The cuff size actually matters. If I put on too small of a blood pressure cuff on an arm, I will get a falsely elevated reading, no different than if I put a blood pressure cuff that's too big on a small arm, I will get a falsely low reading. You have to interpret the number in the context of this patient, the way that was collected and the technique that was done, and also where you're at. You're in the clinic, you're in the emergency department, you're in the hospital, wherever you are at does have some potential weight associated with what do you do with that number. The other thing that goes into here is also think about how patients get their blood pressure checked. They walk in from the parking lot, they hike across the parking lot, get inside, they check in that they're here. If they're brought back, they get their vital signs done, sit down, throw the cuff on, boom. Well, that's not appropriate. You actually are supposed to actually have them rest again and have all those things in the right position to get an accurate reading. So are we really getting an accurate reading, or is this a white coat hypertension or a falsely elevated scenario? And that's where ambulatory blood pressure monitoring or home-based blood pressure monitoring types of things are done, so that you get them out of these environments. You try to assess what's happening throughout the day. And these 24-hour ambulatory blood pressure cuffs, you just wear them like all day long and even while you sleep. And you have this little thing that you clip onto your waist or your belt that just takes it, and you just need to tell the patient, ignore it and just do what you're doing. But when it's taking the blood pressure, just relax the arm and keep trying to do what you're doing. The whole goal is what is happening realistically over the course of the day. Then you have them come back, and then you look at that pattern and see where they're basically hovering, okay? Knowing that some are gonna be a little bit elevated, maybe some are gonna be a little bit lower, depending on what's going on. And then if they meet the criteria of that their blood pressure is still less than 130/80, then you're looking at white coat hypertension, where lifestyle modifications are in play, and then you maybe reassess them again at a later time. Whereas if they're above that, then you start moving to these class 2A recommendations, which is not even a class 1A, which has a higher level of evidence and support for it. So again, are these board exam questions? Well, they can be if they say, consider this, consider that, versus an absolute may not always be agreeable to all clinicians. Right? That's where 2A, 2B start to get fuzzy. It's the gray zone. Well, those become harder questions depending on how they word it. So remember, in just test taking skills, when you're reading a question and answer, if you see a lot of very absolute answer choices, they tend to be wrong. Okay? Because again, nothing in life is very that specific and purposeful. But you want to recheck this within 3 months and make the decision, because you don't want them sitting around having high blood pressure for years and ignoring it, because we know that one of the precursors to developing things like heart failure is uncontrolled hypertension. Yes, it's ischemic disease. Yes, it's valvular disorders, but in this country, it's also uncontrolled hypertension. So what other evaluations should we do based on what you've been given? So what's missing? Well, one of the things missing that we referred to in early on was, what was her weight? Right? She had like 84 kilos or something like that. And remember, she was around the 180s because she had gained 25 pounds over the past year and a half. And I said, well, you can't really discern that, because if she's really tall and already kind of a big person, that might actually be okay for them. But when you're trying to figure out the BMI, and this would be one of the things that you need to know probably how to calculate. There are a number or handful of calculations that are probably appropriate to know, and also how then to interpret. So if they give you the BMI, what does that then mean? Okay, so her BMI is 28, and then you compare that to the ideal body weight and look at her adjusted body weight, and you get a snapshot of where is she at, and then what does a BMI correspond to. But it's not just a BMI. There's also another portion of the exam that a lot of people don't want to do, because it makes people feel a little uncomfortable. They're maybe a little embarrassed. It is slightly personal because you're putting your hands and kind of around someone's waist. But you really need a good waist circumference, okay? Because you're really wanting to measure that abdominal adiposity. Nobody wants you to do that, right? Nobody's excited about having an abdomen that's a little bit larger, you know. So you gotta be, be careful. But hers was 38 inches. So then we have to put that in the context of BMI and her waist as it relates to her comorbidity risks. Because again, we're trying to risk stratify her. We're trying to put her in a bucket of kind of sort of, low risk, moderate, or high risk kind of for comorbidities. And so this is the guidelines for the endocrine group, which pretty much most people follow. It aligns much with the World Health Organization BMI cutoffs. So she was 28. So she's technically classified as overweight, and her comorbidity risk is considered to be increased. Now, if we look at her 38 waist circumference, so you have to look at the gender here because it's going to be different for men versus women. She falls over in this column, and so she's falling into, here she is overweight. She's got a high risk for comorbidities. Okay, and so that just really tries to give you a snapshot. I don't know, Dr. Bolin, if you have anything to add to this particular conversation or point.
They also have staging, so you can classify them by the class, and you can also stage them. Normal is obviously a person who's normal weight, which would be your primary prevention category, and then your stage 0 would be someone more like her, who her BMI is over 25, but she doesn't have any complications from that. Not yet, not that we have identified to this point. She may have,
right.
Which would be a secondary prevention. And then you would move into stage 1, which would be more of your tertiary prevention, if she had a mild or moderate comorbidity. And then stage 2 would be a more severe comorbidity. So again, to this point, we haven't diagnosed her with anything, but there is that staging that you can also potentially put them into to stratify.
And it helps the patient also to see something in a little bit more codified. It helps them to wrap their mind around, well, what does this mean for me? And so, and you can use that as a little bit of a motivator, not to scare them or further depress them, but say like, okay, here's where you're at. The reason we want to be aggressive at doing this, and we can help you out with this, is to reduce this risk. And if we start now, we can stop that from happening, or we can reduce the chance of that happening. And then people sort of tend to get a little bit more motivated by that in most cases, especially if it's presented in a manner that's, understanding. So I just throw out some of these questions out here because, here's a patient who's overweight. What if she came in and said, I hear about these new drugs. I've watched a commercial. I was looking at a magazine and I want this drug to help me lose weight, and so she throws out these words or these terms, or somebody told her that they're on it and she wants to do this too. So when we think about drugs like this that are now used for obesity, weight management tools, we have to think about their pros and their cons. Obviously, what is their just a core knowledge, like what drug class is that? How does it even work? I don't even recognize what it is. And then the pros and the cons, because obviously phentermine, with it being a sympathomimetic and anorexic, has potential problems if patients had structural heart disease, things like that, where that would be a contraindication. If she already has diabetes, or we don't know that yet, but as we work up, let's say she gets diabetes, can we sort of work on two things together? Well, that may be the case. It may be that liraglutide would be a good potential option for if she develops type 2 diabetes and she's overweight, but that's only going to be helpful if she can even get the drug. What if she has no insurance? Or she's, doesn't have a high paying salary job, and is she going to be able to afford it? So thinking about these things, but why would somebody ask for these things? Well, because we all want a pill to solve our problems. I mean, that's what we're used to, right? We don't want to really get to the root of the problem. We just want something else to take it away, and we are a society, especially in this country, where we can go buy something to fix something, or we can take a medicine. My blood pressure's high. Oh, if you take this medicine, it'll go away. So there is a mentality of give me a pill to solve the problem so that I can keep doing what I want to do. I've seen diabetics, and I'm sure, Dr. Bolin, you've seen the same thing, but I've had personal friends who are diabetics, and I've seen patients who are diabetics who, they'll eat a donut and then just give themselves an extra 2 units of insulin. right? So that your numbers don't look bad, right? So they're, but what you're really doing is you're worsening the progression of their underlying problem, right? Which they're going to start having weight gain and issues that's only going to make the situation worse. So we have to try to think of, if we can get to the root of the problem before we just throw a drug on like this, that's not appropriate. We still don't know what the root of the problem is. Why is she gaining weight? Why is she depressed? Okay. Have we finished our workup? And so if she asked for this on the first visit or something like that because she's desperate for a solution, and if you did that, you might actually harm the patient. Okay. So we get some labs back. We did a random glucose, and she has a random of 132. So based on that number alone being random, does she have diabetes? And we're going to talk about the diagnosis of diabetes. And there's a couple of things to think about when you do a random blood sugar, because that's what I do on the emergency medicine side of things, even though it's not outpatient, but I get patients who come in all the time and we will do a random. And there is a category where you can consider the diagnosis of diabetes on a random blood sugar. But her fasting was 115. So now you got to say, well, what does that mean? Is that normal? Is it abnormal? You need to be able to interpret labs. So one of the things that is expected of you on the boards is that you have some knowledge of interpretation of normals and abnormal labs of common things like this. So keep in mind that you need to do that. So she, like looking at the diagnostic criteria for pre-diabetes, okay? So if you see here that this is impaired fast, if for the presence of impaired fasting glucose or impaired glucose tolerance, we look at some things on their lab. So for example, like A1C of 5.7 to 6.4. So it's less than 6.5, but it's still a little bit on the higher end, right? Where you maybe, if you made some lifestyle changes, you could, if you were aggressive with it and disciplined, turn that around. It's not diagnostic yet, but it's getting close and it puts the patient at high risk. Fasting blood sugar between 100 and 125. Well, hers was 115. So she meets that criteria, and it is an 8-hour fast of no caloric intake. And then the older school way, and Dr. Boland, I wanted to see if you'd comment on this, if in your practice, if you guys use oral glucose tolerance tests very much still, but they used to be more common back in the old days. Do you have any feeling on that from a practice, but also board exam perspective?
I have not seen that done in practice.
Yeah, why not? Because
Rarely,
right here, if you look,
rarely.
it says 2 hours.
Well, yeah, because they have to wait and then they have to drink the drink. And
Yeah.
by the way, funny, I don't think the drink is as bad as people make it out to be. But anyway, just from having done it a few times being pregnant. But anyway, no, it's the time and the process of having to do it. So largely in obstetrics, that's when you're going to see that
absolutely.
done, and for a different reason. I've seen it done like super rarely, and before we had some of the continuous glucose monitoring, even by some physicians who were trying to really drill down and get some more data for patients they just really couldn't figure out.
Yeah, agreed. And then of course the diagnosis of diabetes, one of them that falls into this group is the patient who has symptoms, and those are usually like the 3 Ps in most cases, that polyuria, polydipsia, polyphagia, and then you get a random over 200. Any blood sugar randomly over 200 is typically abnormal. And if they're having symptoms associated with it, then that sort of points to the problem. You can still get the A1C and other things to probably validate and prove it, but the reality is it's not normal to be that high. I mean, your body, if it had an appropriate amount of insulin production and sensitivity, should be able to keep it less than 180 in most cases. All right, so is it all about the A1C? Well, this is one of these concepts that I also wanted to see if Dr. Boland would, comment on. But there's a new sort of parameter that you'll see in the guidelines that talk about EAG, these estimated average glucoses, because the reason they advocate, or this is being done, it was a big multi-center international trial that looked at labs and assays to see when this A1C is reported, what is it basically correlating to in the old, trial, the DCCT trial kind of helped us to see a little bit of a pattern of estimation of when the A1C was this, then the person's glucose average is around this area. But this is relevant because patients don't fully comprehend all the time, what is this percentage number that you keep talking about, A1C? When I poke my finger, I get a number like 200 or 150. I don't know what 5%, 6%, 7% means. And so there's this disconnect with what the patient is doing on a daily basis sometimes to assess their blood sugars versus what we are focused on a lot of times, unless you're on insulin. But most of the time, people, like, the big picture is, oh, you're not at your A1C goal. Uh, um, Dr. Bowen, do you have any comments about this and where you see it currently in practice versus a board exam, maybe?
So I feel like you're going to start seeing this on the board exam because they do have the guideline now for the clinical interpretation of the continuous glucose monitoring, and the diabetes guidelines are pulling that in. I think just from a futuristic perspective, you're going to see the guidelines move potentially towards more of a time and range, looking at like 60 to 70% being above goal. Because when you look at this, when you're looking at the estimated average glucose, and you'll have patients come in, and I mean, we've all seen them, their fastings are beautiful, and you're like, oh, okay, you're great, your A1C should be in 7, right?
Right.
And you get it back and it's 8.5, and they're really upset with you, and
Good
they're
point.
really upset in general.
Right.
But what we know is that that is an average. So when you're seeing those fastings that look great post meal, they could be over 200. And then, or they could have an old meter. The meter could be, I mean, there are a ton of things that could play into what
Yeah.
happens with that average. But now that we have the continuous glucose data, you can see where sometimes people are even hypoglycemic, and that balances out that average to bring it to a 7. But most of the day, they're actually living in the 180 mark, but they dip down at night because they're overtreated with their basal or
Yep.
whatever it may be. So you do have those, the interpretation of the CGM that kind of goes along with that, in looking at that estimated average glucose, but it is problematic.
Yeah. So in a lot of labs now are starting to report it. So when they know what the A1C is, they'll report the estimated average glucose along with the lab. So I've been at some hospital systems already that are doing it. Not everybody's doing it, which obviously makes it, again, harder to hold everybody accountable. But once the guidelines really start advocating it, and they know there's going to be a transition period of acceptance, there's going to be a mindset shift even amongst clinicians who are not used to it, and maybe don't do this on a day-to-day basis, like Dr. Boland or something like that. Like I don't look at continuous glucose monitoring numbers. I'm in the emergency department. That's my focus, right? It's not that it's irrelevant, it's just not the thing. So if I'm taking a board exam and I'm kind of outside of an area, it may not be, but you need to start becoming familiar with it, which is why we wanted to present that here, because it's hard to discern when they will start to plug it in on the boards. All right, fasting lipid profile. So our total cholesterol is 209, triglycerides 400. Okay, this is a fasting, so it's not, she didn't just eat, McDonald's or something else like that. LDL of 89, HDL of 40, and a triglyceride to HDL ratio of 10. So what does that mean? Okay, so what do we make of this lipid profile? So let's take a quick poll here. So her LDL was in the 80s. The question is she at her LDL goal? And you don't need to do anything. It's like she's good.
While we're waiting on that, Dr. Busta, I thought
Yeah.
of something. So in looking at that chart, it just dawned on me, you can start to feel like you need to memorize those numbers. But there's a really easy trick that will get you in the vicinity of those numbers. And if you think about an A1C of 7
Yeah.
being an estimated average of 150, and for every percent you go up 35 or down 35, depending on which way the A1C is going, that's a really easy way to get those numbers without having to memorize that chart.
Yeah, that's
And know
that's
where
an
you're going.
excellent clinical pearl for sure. Thank you for bringing that up.
No
Okay,
problem.
we're at 44, almost 50 seconds, and it looks like most of you have, no, not most of you, 66%. Some of y'all having seizures? Come on. All right. I cracked the whip around here. No, just kidding. All right. So, all right. Is her LDL at goal? I'm not sure. Need more information. I like that. Okay. So that is important. I think there's is this person at goal? And some of you said no, absolutely no, and then some said yes. And so I will just tell you, the 24% of you that say she's at goal really need to pay attention to the next couple slides that I'm going to talk about, okay? Because here's this is one of the tricks or problems when you're interpreting a lipid profile. It's not always as clean as you would like it. You have to interpret one number in the context of all of the values that are being provided. But we do have, before I jump to the lipid interpretation, there is a question. Can you repeat the trick, Dr. Boland?
Oh,
The A1C trick.
Sure. So at an A1C of 7, you can consider an estimated average glucose of 150. And then for every
Now remember, guys, it's an estimation.
estimated, yes.
Yeah.
And if you look at that chart, it is going to be off like 2 to 3 points either way of what I'm telling you.
Yeah.
But this is easy. You can do this math in your head and you don't have to memorize a chart. You just got to know to add or subtract 35. So an A1C of 7, your estimated average is 150. So for example, if the A1C is 8%, you would add 35. So your estimated average is going to be roughly 185. And you do that, you add 35 and add 35 and add 35 for however high their A1C goes. And you also drop it down for however low it goes.
Perfect. Love it. By the way, I don't know if y'all see, I'm wearing, I try to wear one of my shirts, like.
I need a shirt. I need to get me a shirt.
For those of you that are pharmacogenetics gurus, right? So it's not the size of your SNP, single nucleotide polymorphism. It's what you do and how you use it. And that's the truth, isn't it? Your SNP is what dictates the expression of what happens. So a little bit of pharmacogenetics tied into that little break right there. All right, so let's look at all the subtypes of the lipid profile. Okay, we've got HDL, LDL, VLDL, and then chylomicrons that differentiated in part not by their diameter or buoyancy, do they float, which is impacted in part by their density. So if you look at the diameter, way over here very big, way over here very small. The smaller and more dense particles, high density lipoprotein, are down there in the bottom. Okay, so their names correlate a little bit into giving you a slight understanding of the size and shape and density of that particle. Okay, so these are all floating around in your blood, okay, especially after a meal. So we have our triglyceride containing particles, which are predominantly our VLDL particles. So your VLDL, your triglycerides that you get on a lipid profile is just a mathematical calculation from the VLDL. Okay, you take your VLDL and you take your VLDL and you multiply by 5, and that gives you your triglycerides. Okay, it's just a math equation. Now, all of the if you look at the non-HDL particles, so LDL, triglycerides, chylomicrons, they all contain an ApoB100 protein on the surface, 1. So that helps you to identify the number of particles in solution. So you not only have size and shape and density, but you also have the number of particles in solution, okay? And the non-HDL parameter on a lipid profile is the poor man's way of estimating the ApoB containing particles. And that's why we sometimes utilize the non-HDL in our assessments of these patients. Now, what happens in patients who tend to have insulin resistance and type 2 diabetes or too much glucose sticking around? What does our body do with it? Well, our body's always preparing for a period of starvation. He doesn't know you're going to eat again in maybe 15 minutes or, an hour, whatever, right? But so our body takes that glucose and it's going to convert it to another source of energy, and that other source of energy is fat, right? So as your glucose gets out of control or elevated, you will produce more triglycerides, because remember, the VLDL is literally a reflection of your triglyceride number, okay? And then as you develop insulin resistance, you can't turn off fatty acids. So you have this huge output of VLDL from glucose being exposed at high levels. You got fatty acids coming into the liver. You're pumping out all this VLDL, but when you do that, it makes the VLDL unstable. Okay, it does these molecules in solution are not very stable, and so they like to play and dance with some of the LDL particles, and they like to exchange some things, right? So triacylglycerol products and then cholesterol esters, and when they do that, it changes the shape of the LDL particles. So you can change the size and the density of LDL particles. And that's very relevant in the context of coronary artery disease and atherosclerotic development. So when you cause a shift in this pattern that goes down to the formation of small dense LDL particles, you're going to have an accelerated, rapid atherosclerotic process in the endovascular lining of the blood vessels. Well, the same things happen with HDL. You can catabolize HDL more readily and get rid of it. So what do we see in a type 2 diabetic pattern? We typically see moderate to low, normal to moderately high LDLs. They'll see high triglycerides, low HDL. Okay, so that's where your triglyceride to HDL ratio can be very influential in understanding what is going on with these patients. So if I got two lipid profiles here, example 1 and example 2. Example 2 is our patient. They both have the same total cholesterol, 209, because it's just an addition. But inside there, those LDL particles are very different. Their sizes and density are very different. So in patients with high triglycerides, remember those LDL particles get smaller. Well, when they get smaller, they take up less space or volume. And so the number is low. Well, what's her LDL? It's 89. So you might go, oh, man, that's a fantastic LDL. We're not going to treat any of that. You don't need a statin at all. In fact, this patient's LDL is significantly worse than this patient's LDL. And this patient here needs a statin faster than this patient. And so this is where interpretation of a number really gets in the way of you treating the problem and also treating their risk, okay? All right, so let's do another quick poll here. So for her, if we were to treat her cholesterol, would it be for primary prevention or secondary prevention for cardiovascular disease? Primary, I'm only going to give you 20 seconds. 20 seconds, which is now up. That's a slam dunk answer. This is primary prevention. Nothing has happened to this patient. It becomes secondary prevention when an event, and that event can be not only a heart attack, but a stroke. It could be a stent placement, angioplasty. They had stents placed in their iliac arteries because they have peripheral vascular disease. All of those things constitute basically an event where you need to be treating them more aggressively as a secondary prevention. So when we go back to looking at drugs and treatments, right? What are some of the things that, drugs that have the greatest evidence both in primary and secondary prevention? Because she's a primary prevention patient. Well, we do have some older trials in the 80s, because back then we didn't have that many things. Cholestyramine, oh, wow. Anybody used that recently? I mean, seriously? I haven't seen that drug in years.
Actually, for diaper cream.
What's that?
It's in some really wonderful diaper cream.
Oh yeah, that's true. And there are drugs that you can bind with it actually too that we use to get rid of, like leflunomide and stuff like that. But gemfibrozil and cholestyramine do have some primary prevention data, but it's old. And these drugs have other problems, and you got to take cholestyramine multiple times throughout the day when you eat. But then most of the data is in statins. Same thing with secondary prevention, lots of statins, and they all show the same pattern, right? So it's very clear that statins do that. So then we look at her, she's in her 40s and doing risk assessments for 10-year estimated risks can only really be done in patients 40 to 75 window, right? That age group is where most of the data is. So we plug in her age. She's 42 years old. She's a female, Caucasian. Here's her blood pressure. Here's her cholesterol numbers. You know, she diabetes and, you know, on a statin. She's not on aspirin. So her 10-year risk is 1.4%, which this risk calculator says is low. Okay. Her lifetime risk is 39%. All right. So then when we go to the guidelines for the dyslipidemia guidelines, and we look at the primary prevention side, there are secondary prevention side. We have to think about how to apply them to this patient. She's in her 40s. She's between 40 and 75, where we do the 10-year risk assessment, assuming that the patient doesn't have diabetes. Does she have diabetes? Well, not technically, right? Her fasting glucose was 115, so that's pre-diabetes. But is she falling in that bucket? Probably, right? Especially if she doesn't do something about it quickly. So here she is. If she was a type 2 or type 1 diabetic, right, then and they're between ages 40 and 75, then we get in a class 1 recommendation for moderate intensity statin. If the patient does not have diabetes, then that's where the 10-year risk comes into play, which for her was less than 5%. So she's in this low risk stratification bucket where you're really emphasizing lifestyle modifications, kind of like the hypertensive situation where somebody's got white coat hypertension, okay? But there's other important things here to recognize. It's not just one thing. So diabetes is clearly a risk factor that pushes people. Obviously, atherosclerotic disease would put them automatically in secondary prevention, automatically putting them into the bucket of needing, you know, a statin in most cases. But there's also these other risk enhancers over here. Family history of premature. Well, does she have that? Remember, her mom had a heart attack at the age of 55. Is that a risk factor for her with a female primary first degree relative? Absolutely. So that's one. Does she have metabolic syndrome? Well, based on her triglyceride to HDL ratio, based on her weight circumference, she sure looks like it, right? Especially if her blood pressure is high, because you see that triad. Does she have lipid biomarkers? Her triglycerides are 400. Fasting. So she's down here. She's over 175. Does she have other things? Well, this is where we do ABIs for peripheral vascular disease. We may check an ApoB 100 or that thing that's non-HDL. And so some of these other things, they're hard to discern from a clinician standpoint. And Dr. Bolin, I don't know if you have any comments here, but when you look at these enhancers, they're not included in this thing over here that makes us feel fuzzy inside that the patient fits right there, right? Absolute. Remember, this is a guide. So what do I do with these? How do they play into this risk? I don't know, Dr. Bolin, if you have an answer for that or how you guys, you know, use it in the clinics and maybe in your own discussions amongst your own peers and colleagues, but thought maybe you could maybe comment there.
Well, it comes down to your experience and your clinical judgment, I think. You know, just based on what type of a clinic you're in, what type of provider you're working with. Are they more aggressive, less aggressive? But the thing that I look at is they really don't tell you what to do with it, which drives a lot of people crazy.
Yep.
But what I would do with this patient from a clinical perspective is have a conversation with them and discuss that further, because you may find, you know, and second degree relatives are not as important, but you may find that their grandparents also had early, you know, cardiac events or things like that. So in talking with them about that, it becomes, to me, a conversation with the patient. And for this patient, again, we don't have all the information yet, but if some of this came to fruition and some of these other disease states were found, it would certainly, well, obviously, if diabetes was found, it would push you and give you your answer.
Yeah.
But I would be inclined to have a conversation about a statin with this patient,
Yeah.
just because we know family history and metabolic syndrome are very important
Mhm.
to discuss. Or maybe even having a discussion about checking a CRP or a calcium score,
Yeah,
or some,
absolutely.
some of those
So
things.
here, yeah, down here, guys, this is where if the decision of risk is uncertain, Dr. Bola mentioning the calcium scores and things like that, coronary calcium calculations, that's where this comes into play to maybe help you and guide you. Because so the point here, guys, is a reminder, guidelines are guides, they're not absolutes. Not a patients don't always fit in the bucket perfectly like we want them to. Board exams will more likely put them in a bucket because they have to. Because if they give you these patients with all these risk enhancers, what do they expect you to do with them? When you put 10 people in a room, they may have different opinions. So that's where your clinical experience and judgment, like Dr. Bolin was saying, comes into play. Also, what Dr. Bolin very importantly highlights, which is again, it's not something that always falls up on a board exam, but it's what something is called shared decision making, right? You tell the patient, here's what we know, here's where you're at. You also have these things. How aggressive do you want to be? Knowing that there's pros and cons to everything that we do. That's shared decision making. Let the patient be engaged in their own healthcare. But that's not going to fall on a board exam because those aren't definitive situations. So we got a couple different scenarios that we could do. One, she may say, no, I can't afford medicines and I want to treat the underlying problem. I want to lose this weight. I don't want to get diabetes. Let's see if I can do that. Okay. We talked about lifestyle modifications just in the previous slide. She fell in the low risk group. What if she didn't, she came back, she did ambulatory blood pressure monitoring and she fell into the white coat hypertension and she was normal, then lifestyle modifications. All right, let's give it a shot. Let's try it, right? Don't typically go longer than 3 months, but let's reevaluate, see if we got the problem under control, right? What if she's pre-diabetic and she's looking for weight loss? Does metformin offer an opportunity potentially here? Maybe. Right? This is one of those gray zone situations. If you're going to recommend exercise, well, what type of exercise do they get? So if you're looking for the most effective way, let's say somebody has a busy lifestyle, there are a number of different types of exercises. There's just brisk walking, and then there's this sort of high intensity training. So if you look at what type of exercise is the most effective at reducing body fat, it's actually sprint interval intensity training where you do these really fast for like 1 minute and then you slow down and you do this and then you just real high sprinting and then you stop. Well, not everybody can do that. You have to be obviously assessed where do you start. Some people start at the moderate intensity continuous, which is sort of that brisk walking sort of scenario. You have to work longer to exert or lose the same amount of fat as sprint interval training would be in a short period of time. So when you look at the most efficient form of cardio, it is sprint interval training, but it's also the hardest. And then which one requires the most amount of time to exercise? The moderate intensity continuous therapy, which is the brisk walking. So you put it to the patient's lifestyle and their situation, and then you can begin to work them up, especially once they've sort of passed certain points, or they may have arthritis or some other problem and they can't just go straight to sprinting. That's not appropriate for patients. So we saw the triglycerides that were really elevated, and we know that triglycerides impact the LDL. She's got risk enhancers with her triglycerides over 175. She's got 400. This is primary prevention. Do we start her on a statin? Well, that goes back to what Dr. Bolin says. This is one of those kind of gray zones because she's got some risk enhancers with a family history. She's got triglycerides that make it a risk enhancer. So I think you could be justified in doing that. Will that show up on a board exam? Probably not, because again, not everybody would fully agree. But if you can get those triglycerides under control, especially if it's dietary influence, like she's drinking Coca-Colas, with real sugar, well, that's just getting converted to fat, all right? And then assessing other risk factors if there is the need to further delineate some of these things like Dr. Boland had mentioned. What about her blood pressure? Again, if she makes lifestyle modifications and she can control it, that's the ideal thing. What if we start her on a beta blocker like metoprolol? You're like, yeah, man, that's great for heart failure prevention in stage B Heart failure, they don't really have symptoms, then we should probably do that effects remodeling and reduce the sudden cardiac death long term. Yeah, but it also causes depression, and she's depressed. You see, so you got to be careful with the drugs that you throw on board. Always try to treat the underlying problem. Let's take as we close this session, we got about 15 minutes left, and I got about 1 minute to transition because we got a little bit of evidence-based medicine biostatistics tonight that I'll be doing after this. But let's take a special case and a unique scenario because there's special populations that need to be factored in as well. So we have a 32-year-old male with a past medical history of bipolar disorder, newly diagnosed HIV. He has been on antiretroviral therapy with what is called 2 nukes, right? Emtricitabine and tenofovir, NRTIs, 2 of them, as part of the backbone, with a PI that's boosted, ritonavir boosted lopinavir. Okay, so this is a PI-based regimen. He's been on it for several years. After you finally see him, he was put on it. We followed him up. He's identified lipids and glucose being abnormal. Wants your input because he is an ID physician, not a cardiologist or lipidologist. So the patient smokes, drinks, but no other real drug abuse, has an allergy to sulfa. You look at his blood pressure, pulse looks okay, oxygenation looks okay. His exam is basically normal, right? There's nothing really there, okay? When you look at his labs, his glucose is 115. Again, you can assume on this one, this is fasting. AST, ALT is within normal limits. You can see that his total cholesterol is 244, which is elevated over 200. LDL of 160, seems kind of high. HDL is low, and the triglycerides are high at 220, okay? So what's our plan? Well, let's talk about HIV patients here for a quick second. All right, so should we calculate a 10-year risk score to determine if he is above 7.5%? So 1, are we in primary? And based on his age. I already gave you the answer earlier, so I'm kind of wanting to see if you were listening. And I'm only going to give you all 30 seconds because we are running out of time, and I want to make sure we finish the last couple points here. All right, 64% of you, come on. No slackers. I love y'all. I really do. All right, so the answer is yes, okay? And so let's, when we look at this patient, going back, when you look at the patient, he's 32 years old. So, well, wait a minute. What's the cutoff, right? So when you look at the cutoff, it's 40, and most of the data is around 75. Some people will go up to 80. I've actually seen calculators use age 20. They're basically looking for adults. But this is from the American College of Cardiology. This is their calculator. And so technically, if you were to try to put this in, it would give you an error message because there's no, according to them, that evidence-based, it's not. So, that's where the answer is technically no. So these are like tools where you risk stratify people. You need to know the context of their evidence to know how to appropriately apply them. That doesn't mean you can't ever use it. You just need to know that the data, if you're a purist, falls into that group. So what do the current guidelines say about HIV patients with dyslipidemia? They don't say anything. Treat them with Zetia. All HIV patients should be treated aggressively with statins. I'm in the middle of an absent seizure right now. The Napoleon Dynamite look, right? The lip hanging down, like drool coming out of your mouth, a web flying off your hair, just standing there staring off into the space. Some of you might look like that right now. Just kidding, gosh. Yeah, Steven, my man. You're not gonna be friends, man. Okay. I need to share the results. So let's see what y'all say. All right, they don't say anything. Treat them with Zetia. Yeah, they do. They may mention something about that. All HIV patients should be treated aggressively. Remember, be careful with extremes. All? Really? And aggressive? There's a lot of drug interactions with statins, depending on which and PIs, protease inhibitors. So, but we're happy that 6% of you are currently having absence seizures. We'll send some ethosuximide your way. Okay. All right. So as we again look at the guidelines, when we look at the risk enhancers, again, if you look over here, they say inflammatory diseases, especially rheumatoid arthritis, psoriasis, and HIV. So they do very much specifically call out. Now it's in a small fine print, but it's still there. Okay. And so again, this is an enhancer. This patient's in their 30s. So, you know, what do we do with this? Because there's no arrow down. You see that? It stops right there. So consider statin if family history they have premature, or if the LDL is greater than 160. And I think his LDL was greater than 160. So, you know, then you got to have that conversation where you're walking a little bit into the gray zone, and you got an enhancer risk. When you say, well, what risk does HIV really have, and why are they picking on it? Well, if you look right here, so HIV, and you look at right here, it's a 2A recommendation, right? So chronic inflammatory disorders or HIV, we should do a fasting lipid profile, do a risk assessment to be helpful as a guide to the benefit. But not everybody's going to agree with that. And if you mix the wrong statin in this patient, you could significantly cause a drug interaction that would cause either hepatocellular damage or even myositis that could lead to rhabdomyolysis. So one of the classic pharmacokinetic drug interaction studies with simvastatin and saquinavir that resulted in a 3,000% increase in simvastatin levels. Well, we know that statins have a concentration or dose-dependent increase in the risk of liver and muscle damage. And so that would be absolute contraindication. And I've actually seen that happen. So is there any evidence? Well, the DAD study is one of probably the largest cohort sort of studies that were done. It comprises of multiple cohorts in Australia, Europe, and the US. They've been monitoring patients since 2009, and they've been periodically doing assessments. But what I try to highlight here is the risk of cardiovascular disease clearly is increased compared to patients not exposed, so 4.9 events per 1,000 person years versus 13.6 events per 1,000 person years in those on ritonavir boosted regimens. And this one was an example of darunavir. They talk about those that were put on ritonavir boosted atazanavir, though, having less pronounced cardiovascular disease. And the reason for that is atazanavir uniquely is a protease inhibitor that does not cause as much glucose sensitivity problems, and so it doesn't get as high, and their lipid profiles are not as bad. They still get bad, but they're not as bad. In fact, back in the day when I used to manage these patients, we would manipulate their protease inhibitors to treat the HIV-induced dyslipidemia. Now, you don't want to do that without consulting with an infectious disease HIV expert, but the point of the matter is it is an option, antiretroviral switching, for the purpose of treating not only the HIV, but also reducing their cardiovascular risk. Now, that's from the DAD studies that we sort of extrapolate from that. There are other treatment options if you can't use statins. Omega-3 fatty acids have been studied up to as high as doses of 6 grams per day, as well as Zetia, without causing drug interactions, okay? If you do use statins, low-dose atorvastatin, pravastatin, rosuvastatin tend to be okay. Rosuvastatin becomes a little bit problematic if you have an atazanavir-based regimen, because atazanavir inhibits BCRP removal of rosuvastatin. So it's an efflux transporter inhibitor that would raise the concentrations of rosuvastatin, and that was a pharmacokinetic study, drug interaction study that we did couple of years ago. And then of course checking other labs and doing lifestyle changes. So there's sometimes more than one way to manage these patients who have special patient population situations. Okay guys, we are done with our ambulatory care, primary care, chronic sort of approach to management of patients session. We will typically alternate back and forth between acute care or chronic care and acute care. Again, look at the website for the dates and the topic areas if you are studying for a specific exam where you feel like it might be applicable to you. Those of you wanting to get your live CE, you only have 7 days to do that. Otherwise, you will have to do the I think you have to do the home-based, or it's a different CE. But all the instructions are on your form that are available on your little thing here that you can download. It's PDF. Please follow exactly every step of the recommendations to get your CE, and recognize that your CE does not show up in the CPE monitor immediately. It takes up to a week for UT to communicate all of that to the main system that would then eventually get leaked. So be patient with that. All right, we've got 5 minutes before I have to start another session. And for those of you that are also joining the EBM Biostatistics, then we'll see you guys in a few minutes. But we probably need to take a little break here as we transition. And my friend Steven here is voting for Pedro. For those of you, I hope to God y'all know who Napoleon Dynamite is. If not, that's something you need to write down and to do. All right, we don't have time for questions, unfortunately. Oh, there's somebody here that graduated with you.
Oh, nice.
She knows me. She knows me as Daniel.
Oh,
Stephen
yes.
Moore. Okay.
Yep.
Anyway, okay, guys. All right, take care.
Bye.
Bye-bye.